Can I just watch that for the next hour?
Yeah.
And then go home and be jealous my dog's on puppy.
For the most part, with the beta blockers, if you will think about what they do in therapeutic doses, it's pretty easy to predict what they'll do when you overdose them. And if you think about what they're blocking, that pretty much will lead you to what you're going to do to treat them. So, just looking at the adrenergic receptors that are in the body, what do alpha 1s? And what are the stimulants? What are the neurotransmitters? What are the adrenergic neurotransmitters?
Norepinephrine.
Norepinephrine. Some kind of cold.
Yeah.
Think pack rat. It's coming. So start thinking through these things. Okay, so norepinephrine and epinephrine are what do they do? They agonist or antagonist to these receptors? They're agonists. So if you have a catecholamine that stimulates an alpha 1, what's going to happen?
Vasoconstriction.
Vasoconstriction. Okay. Okay. Where are the beta 1s? Where are the beta 1s?
Heart.
So what's going to happen if you stimulate beta 1s?
Increased heart rate.
Heart rate goes up. And if you stimulate where beta 2s primarily?
Lungs.
Lungs. And they're also in skeletal muscles. If you stimulate them, what happens?
Bronchodilation.
Bronchodilation. And in the skeletal muscles, what happens? Vasodilation.
Oh, yeah.
That's why you get, it's always weird about, so here we go. Okay. So when we give a beta blocker, what happens? We block all those receptors to an extent. They're antagonists, right? So if we block an alpha 1, what will happen?
Dilation.
We'll get vasodilation. If we block a beta 1, what's going to happen? Heart rate's going to go down. And if we block a beta 2, we get bronchoconstriction, so their breathing gets worse, and we get vasoconstriction in the skeletal muscle. Okay. All right. All right, so this is not an uncommon overdose, because think about how many times we have talked about where a beta blocker is used. Name me some indications for beta blockers. Heart failure, hypertension, what else? Say it again. Arrhythmias, okay. What else?
Headaches.
Headaches, migraines. Say it again. Anxiety? Performance anxiety, okay. Tremors, essential tremors. So lots of places we use. What about hyperthyroidism? Okay, so lots of places where it exists. So if you have grandparents who have a beta blocker around, then little kids can get in it if they're not storing it appropriately. You'll see on that list there, most of the time, these are unintentional. About 30% are intentional. Tends to be younger women, higher association with depression. All right, so of all of them, propranolol is the major one. We'll talk about why that is. Okay. So all beta blockers are not the same. So you can see different toxicities based on the beta blocker they take. And there in the middle, they're listed. Some of them have membrane stabilizing activity. So those tend to have more antiarrhythmic. Sotalol would probably be the giant in that group. Okay? And we use it as for multiple types of arrhythmias. If you look down just a little bit further, it shows you they inhibit the fast sodium channels. So they widen the QRS interval. So as heart rate goes down, QRS gets wider. Go back and look at that arrhythmia lecture that I gave you. Okay. So so for propranolol, the majority of them are going to affect phase 4. So what they do is they raise that threshold for depolarization. Okay. So the red is normal, and the black is the beta blocker. So you'll see that the time in phase 4, it increases. Threshold is the same, depolarizes, but the QRS is a wider. So what kind of arrhythmias can you get when you widen that QRS? Okay, we're going to hit that. I don't know. I don't know that for sure. Torsades is the worst. Remember how we talked about malignant arrhythmias, pro-arrhythmic? Sotalol is famous for it. That's why we put them in the hospital when we started on it. Sotalol affects not only sodium but also potassium, so it tends to hit phase 3. So it's a little bit different from the garden variety beta blockers. Some of them are lipophilic. Propranolol, most lipophilic, which means what?
Easier to get through the membrane.
Easier to get through membranes, and the membrane it gets through that makes it worse is the brain. So propranolol, so seizures, hallucinations, delirium are going to be more common with that agent. Intrinsic sympathetic activity. So we don't use these very often. One of them to remember is acebutolol. Pindolol also. So it'll say beta blocker with ISA, intrinsic sympathetic activity. So they're partial agonists. So the reason where you would use these would be in heart failure more often. So in untreated heart failure, often that cardiac support and drive is due to the sympathetic system. When you knock that out with a beta blocker, they go into heart failure sometimes. Okay? So sometimes for some people, it's good to have a beta blocker that does the great things that a beta blocker does in heart failure, but you also don't take away that sympathetic drive so their heart will keep going. Okay? So those have their own particular problem. Acebutolol of all the beta blockers is one of the most toxic, and it is in that group. So less likely to be bradycardic, less likely to be hypotensive. So when you have somebody come in, the one thing you want to do is you want to know which beta blocker was it. And we're going to talk about some of the differences that will happen with these beta blockers that are in different groups. For the most part, beta blockers are short half-lives. So because of that, what do we do to help adherence when we're treating hypertension? We give up, well, we dose them frequently, but what have they done? The pharmaceutical company has done what? Extended release. So guess what? When you have a overdose with an extended release, it lasts longer, okay? So you get effects for hours to days instead of very short term. And the onset can be delayed, okay? So think that. You know those things. Okay, they came in, they're on this for hypertension. The son's telling me she takes it once a day. It's like, bingo. Extended release drug. Okay. Sotalol, risk factors for toxicity. Taking it with another drug. Always think multi-ingredient ingestions. It's rare that people have one drug that they take. So think, what else could they take? If they were taking it for heart association, what else could they also have taken it with? A lot of those drugs come in combinations. Beta blocker, ACE inhibitor. Beta blocker, maybe also a diuretic. Okay? So start thinking, what else could they be on that could do this? Are they also on an anticoagulant? Because they're taking it for, I don't know, a heart valve. Atrial fib. Okay? You're on Plavix and aspirin and an anticoagulant. Okay? Think other things that they could commonly be on. One of the exceptions is sotalol. Much longer effect, somewhat delayed, but longer toxicity. So it's kind of in a category all itself. Okay, so look on page 13, cardiovascular effects. So bradycardia is going to be a hallmark, right, for the most part, unless you got a one with intrinsic sympathetic activity. But for the most part, their heart rate's going to go down. Hypotension. Why are they hypotensive? Vasodilation. So you've got alpha-1, you block that big time, and you've got skeletal muscle also where you've got lots of vasodilation. So total peripheral resistance goes way down, and their heart rate goes way down. So bradycardia and hypotension should start to make you think towards a beta blocker or a calcium channel blocker. Ventricular dysrhythmias. You have really disrupted the conduction speed through the heart, right? Where do you see the big effect from beta blockers on the heart? What structural part? SA node and also AV node. Okay. So what are you going to see on an EKG? A prolonged PR interval, right? I told you some of them can increase QRS interval, so QT interval could be increased, especially if they're profoundly bradycardic. Okay. So you can see junctional rhythms, right? You can see first, second, third degree AV block. Mental status changes, so especially with the more lipophilic, propranolol being one of the more common, delirium, coma, seizures. Also because their blood sugars can go way down, that also could be contributing to that neurologic deficits. Respiratory depression, central action, but also due to effects on the lungs. Bronchospasm would fall into that also. Hypoglycemia, why do they get hypoglycemic? It's a liver effect. Okay, so adrenergic receptors have some control over glycogenolysis. If you can't break down the glycogen, you can't release glucose. Okay? So, kind of an odd, we don't worry about it so much when we're doing therapeutic doses. Even though you know that sometimes we worry about people who have, that we can make diabetes worse, that's affects more on insulin release. This is an effect on the liver. Also, catecholamine release, remember, is one of the ways that we can raise blood sugar quickly by epinephrine's effects on liver cells to break down glycogen and release glucose. You block that. Okay? So glucose, you got to think also glucose when you are doing these overdose with both calcium channel blocker and beta blocker. Toxicity of specific drugs. Acebutolol, one of the more potentially toxic. Not used very often. Propranolol, acebutolol, betaxolol, oxprinolol. Again, cardiovascular toxicity because of dysrhythmias. You've got that membrane stabilizing action. And then sotalol, the worst thing with sotalol is QT prolongation and the higher risk for size. So sotalol overdose, think malignant arrhythmias. VTAC, VFib, torsades. So what should you do? Well, get an EKG. See what's going on with the heart. You all mentioned most of those. PR prolongation, QRS widening, any Brady arrhythmia can occur, including asystole. So that can be cardiac death. You want to get a finger stick blood sugar, because that could also go to their, what's going on with their neurologic. They could have taken a combination of a diabetes medicine to lower their blood sugar and a beta blocker, because a lot of our diabetics are on beta blockers as well. Also calcium, because we are going to use that calcium. So now you got to think of what can you do to overcome it. You got to support the heart. It's hemodynamics that are the big problem here. So what are you going to use to try to keep the heart and the circulatory system going until you can clear the drug? So kidney, calcium, and we're going to use insulin and glucose in these folks as well. We'll talk about why on the next page. So gut decontamination, you can use activated charcoal with the beta blockers. So what do you do with hypotension? Well, you start with isotonic fluid. Give me an example of an isotonic fluid. Normal saline. What would be another? Lactated ringers. Symptomatic bradycardia, we're going to use atropine. Why would we use atropine? What is atropine? It's a what? What type of drug is it? It's a what? It's an anticholinergic. Why do we use that? What are we trying to do?
Fix the heart.
What are we trying to do specifically?
With the heart.
We want the heart rate to go up, right? Okay. So, SA node. Intrinsically, the SA node will beat at about 100 beats a minute. Why do we not all beat at 100 beats per minute? Parasympathetic system has the brakes on it, right? Okay. So if we can knock that effect off, we can allow, with the atropine, parasympathetic agent, acetylcholine, right? Antimuscarinic, decrease the effects of the parasympathetic system on the SA node. We might be able to get the heart rate to come back up. Right? Arrhythmias, sodium bicarb. Sodium bicarb is often used in situations, emergency situations when you have QRS widening. For some reason, it helps to narrow that QRS. And to Dim's chagrin, we do not know exactly why. It may be the sodium amount. It may be the change in pH. Okay. So that's why sodium bicarb is used. If they respond, if the EKG responds, sometimes they'll put them on a low-dose infusion. You don't want to make them alkalotic, but you're going to use that. Max sulfate. Remember when we talked about the antiarrhythmics, the two things you have to pay attention to are potassium and magnesium. If they're hypokalemic, it is hard to get them treated unless you also are going to treat the magnesium low. Okay. So we're gonna give them, we're gonna use that to our advantage too. So magnesium if the ventricular arrhythmias are present. If their blood sugar's too low, we're gonna give them dextrose because they can't do it. You just have to give them the glucose because they can't get it any other way. With seizures, we're going to use benzodiazepines. Generic approach. All right. If when you're studying that, if you'll really think through what's happening with the use of that drug and what am I trying to reverse, and think through how each of those are going to help based either on what you know or what I've just told you, it will start to make sense. A tried and true drug that's been used forever and has some evidence is using IV glucagon. Now, This isn't to get them to raise their blood sugar. It is to get their, it has effects on calcium. So this picture, what this picture shows you is the different ways you can treat a beta blocker toxicity. So here's the beta blocker sitting on the receptor. You've got calcium you can give, and you can give calcium. You can give IV calcium. The other is that you can give glucagon because it works on these receptors and that intracellular signaling that will allow those calcium channels to open up and more calcium move in, so that we can restore the ability of that heart muscle to beat, right? Now, the problem with in less serious overdoses, it will probably work, but it's usually not a sustained treatment. It doesn't. It'll work for a little bit and then it attenuates. So sometimes you have to move to other things when you do it. So you're trying to increase intracellular calcium. I'm talking about tachyphylaxis. The effect is usually pulse will increase, blood pressure will come up. So ADRs, vomiting, you can use Zofran. And another would be hyperglycemia. You can see that, right? If you can get the liver to respond to it, that's the main. Glucagon is produced where? Which cells of the pancreas? Alpha cells of the pancreas. And glucagon is what is working in you all right now to keep your liver producing glucose, right? It's the big person on the teeter-totter, insulin, glucagon, right? Mm-hmm. Okay, so you can see why they could get hyperglycemia. IV calcium can be used because you want to increase force of contraction, right? So a lot of this is overcoming. So a lot of times with drugs on receptors, the bigger thing is the person with the most toys wins, okay? The person with the most weapons wins because you can just overcome. So a lot of it is trying to overcome the effect of an agonist. Go back and look at when I talked about agonists, partial agonists, and absolute antagonists. Those partial antagonists can be overcome. You just give more of whatever they're antagonizing. That's what we're trying to do here. So we're going to give calcium to overcome that. There are two different salts. There's calcium chloride, calcium gluconate. Their dose will differ. This is true no matter what you're using IV calcium for. You got to know the salt. Okay? Gluconate, chloride. Vasopressor. We can use a catecholamine. Epinephrine. We can overcome what that beta blocker is doing at the receptors if we can use a vasopressor like epinephrine. In lesser overdoses, these will usually work. When they don't work, then one of the interventions that they are now using are high-dose insulin and glucose. And it isn't for the blood sugar. It's for the hemodynamic effects on insulin. We don't see it usually when we're using it in the doses we do, but when you use high dose, you get positive inotropic effects. You can reverse the ischemia in the microvascular, so you can improve the circulation. It also will help the heart use the nutrients that are around it, like it'll help it to use carbohydrates to do the work that you're asking it to do. So it's things that we don't usually think about, so you need to make a note. So positive inotropic effect from the insulin, vasodilation in the microvasculature. So the little vessels are going to benefit from that insulin being present. It also makes it more responsive to the catecholamines. So it will improve the response to epinephrine. And it helps the heart use energy. And usually it will stabilize an acid-base environment. So they're less likely to go to metabolic acidosis, which causes all kinds of trouble. Okay, so things you usually don't think about, very high dose. So it's usually if these other interventions are not working, that is when you turn to high dose insulin and glucose. And the glucose is just to support the use of the insulin. So they're usually given a 5 or 10% dextrose. So you can do a 5 or 10% dextrose peripherally. You go higher than that, you burn the veins, and you have to go to the veins. One other method that is used, and you will see this in other drugs that are lipophilic, is the use of lipid emulsions. So we talked about this with amphotericin. Using lipid emulsions help decrease the toxicity of the amphotericin. But that was how it was formulated. This is using a lipid emulsion to draw those drugs in. Okay? It's kind of like a weird way of doing a dialysis. You're drawing the drug to the fat. It only works for lipophilic drugs. And it is kind of a out there therapy. You'll see it mentioned a lot, but in terms of protocols and exactly how to do it and when to do it and how much to do, probably is going to be more likely people who do it all the time are probably going to have protocols. All I can tell you is that it's one of the end things that people think about doing if they can't get them to respond to other. The insulin seems to also have a dose increasing effect. So the higher the insulin dose you give, the more the effect you get. So it doesn't tend to be one of those ceiling type drugs. Isn't that cool? I think it's interesting. Okay. So also remember, when you use insulin and glucose, where do you drive the potassium usually? Inside the cell. So you've got to watch potassium when you're using that therapy. Okay. So these are usually short-term overdoses to treat. Very different from Tylenol or iron that we're going to see. Okay. So especially if they did an immediate release, these are going to be folks that you're going to be able to usually stabilize and get them out of the hospital within a few days, if not less. Sotalol will take longer. Here again, this is the up-to-date flow for the treatment of beta blockers. Okay. Now, since you know beta blockers, calcium channel blockers follow almost the same path. Okay. So remember, we got two types of calcium channel blockers. What are they? What are the big groups? Dihydropyridine. Give me an example.
Nifedipine.
Okay, look at your sheet down there. So we've got dihydropyridines, those are nifedipine, amlodipine, felodipine, nicardipine. Mostly the ones you know would be amlodipine. They are mostly peripheral actors, vasodilators, tachycardia. They don't cause so much problems. The myocardial toxins are the 9-dihydropyridine, verapamil, diltiazem. They work in the heart. What's the big thing if you give too much verapamil, what happens? It's a negative inotrope, so you get heart failure. Diltiazem tends to be a little bit more balanced, it's a little bit more AV node, but these are the ones that are going to cause you the cardiotoxicity. And we almost always give them as an extended release, almost always. Diltiazem controlled release once a day. It was a 6-hour drug before they came up with that. So that's the problem with calcium channel blockers. I would just always assume they've taken an extended release. These are toxic drugs. Look at the top. In 2015, 5,000 cases of overdose resulted in 25 deaths. This is higher than you see with beta blockers. Beta blockers are more common, calcium channel blockers more lethal. Of those cases, about 25% were in kids younger than 6. So it tells you. And we use calcium channel blockers for lots of different things. So it could be parents that have them, and grandparents as well. So 16% of all cardiovascular drugs are calcium channel blockers, and it's almost 40% of the deaths. So it tells you, respect those calcium channel blockers. All right, symptoms similar to what you see with the beta blockers. Hypotension, bradycardia, PR interval gets prolonged, bradyarrhythmias. Now here you can get hyperglycemia. Treatment, same kind of thing. Decontaminate the gut if they're early enough. Intralipid therapy, again, is mentioned here because these drugs are lipophilic. So it's stabilize their airway, give them isotonic fluids to treat their blood pressure, atropine. And atropine's going to do what?
Increase the heart rate.
It's going to increase their heart rate. Give them, now you've got calcium channel blockers, so we're going to use calcium to overcome it, right? Glucagon can also be used. Next page, same thing, you can go to insulin and high-dose insulin and glucose. Same thing. Watch the potassium and magnesium. Use a vasopressor if you can't control the blood pressure otherwise, or hemodynamics otherwise. And there's your list. So very similar. I would just learn the differences. Okay. Did you talk about iron? Overdose? A little bit. Iron is a bad one. It's a bad one because usually it's kids. And it's usually because the people who are most likely to have iron are who? Pregnant women. So look down there. Let's see. Second, unintentional ingestion. The birth of a sibling within 6 months has been identified as a risk factor for iron poisoning in children younger than 3. Okay. So warn those moms. The other problem is how we market those iron products. If you were a kid, would you be drawn to them? So there's the good and the bad. We've got gummies, and they've got iron in them. They've got vitamins. They are low doses of iron, but for a little kid, it doesn't take a whole lot. Okay. Then we've got these chewable vitamins that we have put at Trader Joe's in a bear. We've tried to make them look non-threatening. I don't know why that little monster is supposed to be appealing, but maybe it works. You got the Flintstone gummies, you got the prenatal, everything's a gummy now. So you got to be careful. You got to warn your moms. Okay. All right. So the toxicity with iron is a milligram per kilo, and we're going to go through that. Ingestions of more of 60 milligrams per kilo are usually a problem. These drugs, when they get in, are free radicals, and the liver takes it up passively. So the liver gets the brunt of the toxicity, and it can be delayed. The child can eat it one day and not show up for 2 or 3 days without symptoms, and then they are too far gone. So there is an antidote, but the big thing is recognizing early what is happening and treating it. So the first phase is the GI phase, and this lists the 5 different stages in time frames. So one of the good things is that iron, you remember we talked about how hard iron was on the stomach. People don't usually tolerate it very well, right? It hurts their stomach, they get constipated. Well, this is one of the things that's in our favor, is that it is hard on the GI tract, so abdominal pain, vomiting, diarrhea, throwing up blood, pooping out bloody stools, lethargy, shock, metabolic acidosis. Vomiting is the most sensitive indicator of a serious ingestion. So hopefully a mom would get the kid to a facility for evaluation. Then they go into a phase where those symptoms go away because they've absorbed it. So it's out of the gut, now it's going to the liver. And so it takes a while for that liver toxicity to show up. And that's that third step, is 6 to 12 hours after. So cardiovascular toxicity, coagulopathy, you've killed off or you've damaged enough of those liver cells that can't produce clotting factors, which adds to all the problems. So jaundice, coma, worsening coagulopathy. These kids are sick. They do look toxic at that point. The hepatotoxicity and hepatic necrosis occurs in between day 1 and 4, and this is, if they're going to die, it's usually in this phase. And then the bad side is down the road, they can get bowel obstruction and strictures from the damage that's been done to the intestines and then the resulting inflammation and scarring that takes place. So nasty. That's why you've got to talk to your patients about keeping the iron out of the way of kids. So look on page 21 under serum concentration. So one of the things you would do is you're going to draw a serum concentration. So if it's less than, if their iron, they do have some capacity to absorb this iron. Think about your transferrin and your ferritin. So they can absorb some, but usually you're going to overwhelm it in an overdose. So 350 micrograms per deciliter, usually minimal toxicity. 350 to 500 correlates more with your GI side effects. Greater than 500 is a serious, and 1,000 is usually deadly. So it lists other lab there to get your kidneys, your blood counts, your PTs, your type and cross-matching in case you have to give blood. And in the past, they recommended doing a radiograph. I don't know about the gummies. Here's a kid that ate a lot of iron tablets. So the radio-opaque, they show up. So some of the protocols we'll talk about, if their level is this and you can see pills on the x-ray, then this is the treatment indication. So management, gotta evacuate the gut, the whole gut. Iron isn't well absorbed by charcoal, so we don't use it. Iron deferoxamine, this is the antidote of choice. It's given IV. It's very effective if given early. It chelates the iron, ties it up, can't do anything. It does turn their urine a red color. That's the least of our worries, and it's not harmful. So indications for the deferoxamine: severe symptoms, an anion gap metabolic acidosis. Iron levels greater than 500. Significant number of pills on the x-ray. Okay, so it's given IV. You see the rate is 15 milligrams per kilo per hour up to a max of 35. For the most part, well tolerated. Hypotension is one of the problems. Also, acute respiratory distress syndrome can be problematic as well. The biggest thing with iron is early recognition. If you got a little kid and they're coming in and they think they're taking stuff, always get an iron level and look for it. Okay. Questions about iron? Okay, let's look at opioids. Have you talked about opioid overdose? So poppies. Okay, so are growing poppies in the United States illegal? No. I always wonder who was the first person who thought to chew the leaves, chew the stem, eat the seeds. I just wonder what goes through. It's got to be men. It's like beer. Who thought beer smelled good enough to drink? No. Okay, so,
Paul, are you fielding those questions?
Blue Moon smells and tastes great.
Is the same with coffee? Didn't they just like boil it?
So this has been a problem for a long time.
I watched this.
Go ahead. better brain starts with looking at something old and saying, really? So we build capital?
Now, I will eat.
Tell me you sing this
With attractive to the eyes and soothing the smell. Hobbies will put them to sleep.
This is a great teacher about opiate overdose. Watch how they do it.
There's your book city. Oh, we're almost there. It's beautiful, isn't it? He really must be a wonderful wizard to live in a city like that.
Well, come on then. What are we waiting for? Nothing. Let's hurry.
Yes, let's run.
Come on. Hurry.
What's happening? What is it? I can't run anymore. I'm so sleepy.
Here, give us your hands and we'll pull you along.
Oh, no, please. I have to rest for just a minute. Toto, where's Toto?
Oh, you can't rest now. We're nearly there. Don't cry. You'll rust yourself again.
Come to think of it, 40 weeks wouldn't be bad.
Don't you start too. Oh, we ought to try and carry Tom. I don't think I could, but we could try. Then, yes. This is terrible. Here, Tin Man, help me. Oh, this is terrible. You can't let your event. This is a spell, this is. It's the Wicked Witch. What do we do? Help! Help! It's no use screaming at a time like this. Nobody will hear you. Help! 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 No, it isn't. Yes, it is. Maybe that'll help. Oh, but couldn't help. Does help. Dorothy, you're waking now.
Unusual weather would happen, ain't it?
Look, he's busted again. Oh, give me the oil can, quick.
Here.
Oh,
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 he is rusty.
here.
Here.
Oh, quick. Oh, oh, curse it. Somebody always knows that girl. But shoes or no shoes, I'm still afraid enough to conquer her. And won't lose a friend. Come on, let's get out of here. Look, Emerald City is closer and prettier than ever. What you're out of the night, you're out of the night. Step into the sun, step into the light. Keep saying more than more story. The caves of the earth, for the stars. Hold on to your breath, hold on to your heart, hold on to your heart. March up to the gate and feel it open.
Somebody understood opioid overdose. So when they started into the poppies, what symptoms of overdose did she have? CNS sedation, right? She went to sleep. Okay. What did the Tin Man and the Scarecrow do that they should have done? What did they do? What was their reaction? They recognized something was wrong, didn't they? And they called for help. Isn't that what we need to do when we recognize overdose, opioid overdose? I don't know who came up with that word. Then Glenda comes. And what did she do? She gave them an antidote.
Yeah.
I think she's a wannabe. So she gave them an antidote, and how fast did it work? Like that, just like Narcan does. And then they get up, and they're pretty normal, aren't they? Right? Yep. Which most of the time when we give Narcan, if it's been opioid, they all come right back to normal. And they go off singing, and the words, I listened to in this time I drew up the lyrics. Hold on to your breath, hold on to your heart, hold on to your hope. I thought, you know about opioid overdose. It's exactly it. Because our goal when we treat Narcan is to get them to breathe. It isn't to get them to come back to full consciousness, it's breath. It's because respiratory depression and then stopping breathing is what kills them. Great learning tool. Okay. So, let's see. So here's what we know about the opioid crisis, because it's now a buzzword, so it's on the news. And since y'all don't, is it on your Sling or Hulu? Do they do opioid documentary crisis day? Okay. So roughly 21 to 29% of patients prescribed opioids for chronic pain misuse them. So high percent. About a quarter of those are going to become abusers, or they now call it opioid use disorder. And of those, they can go on to heroin. So if you take the opioids away, they often will substitute heroin. 80% of people who use heroin first misuse prescription opioids. So it's probably the way they are made. It's probably the way they are wired in terms of addiction. Opioid overdose increased 30% in about a 9-month period in 52 areas in 45 states. Midwestern region saw overdose increase 70% from July of 16 to September of 17. So quite a problem. Started in the 90s when a lot of these opioids became available. We suspected that they had a very low abuse potential, and so they were just prescribed like water. And so now here we are. So you can see it's pretty much, it's very much an East Coast. If you watch the news at all, they talk about New Hampshire a lot, and the deaths there are very high. We're in the second tier of 10 to 14 overdose deaths per 100,000. Let me give you some other data. In 2016, in Oklahoma, there were 444 opioid deaths. We had a lower death rate than the average, though. We have 11.6 per 100,000 people. National average is 13.3 deaths per 100,000. But our heroin use doubled during that time, and our deaths from heroin doubled also during that time. And the opioid deaths went down. This I thought was interesting. In Oklahoma, I checked this twice because I found it hard to believe. About 4 million opioid prescriptions written a year. This was in 2016 before I started doing all the correcting. But we wrote 101.7 opioid prescriptions per 100 people. That means everybody got more than one.
Wow.
Yes, that's what I checked it twice. National average is 70. 70 prescriptions per 100. So you can see how don't record this part.